So what is spinal cord stimulation? It is when stimulating electrodes are placed in the epidural space overlying the dorsal columns of the spinal cord in this fashion. More than 20,000 stimulators are implanted each year. So this really is a pretty common procedure and quite a large market. The mechanism of action of spinal cord stimulation is truly not very well understood, but it's been centered mostly around something called the gate control theory, which was first proposed in 1965 by Melzek and Wall. And that generally explains that the spinal cord contains what they would call gates that allow pain signals to be overridden by other less noxious signals like light touch. So this is the thought process behind, say, why rubbing your elbow like this could provide temporary pain relief after an elbow injury. In terms of spinal cord stimulation, the idea is that by stimulating the more robust A beta fibers traveling in the dorsal columns that you can see here, we can gate out the nociceptive information carried by the smaller alpha, delta, and C fibers. And as a result, the brain will perceive a tingling sensation instead of a sensation of pain. Now, this is thought to occur at the level of the dorsal horn with the activation of inhibitory interneurons, but really may occur anywhere along the pain pathway or maybe even in the brain. Now, a brief note about patient selection. When considering patient selection factors, it's really important to keep in mind that the ultimate goal of this therapy is to improve quality of life by reducing the severity of pain and its associated characteristics. So what are some of the approved indication? Well, the most common one, at least in the United States, is something that has been termed failed back surgery syndrome. And I think it's worthwhile taking just a moment to define this rather nebulously defined and rather general term, which can be a little bit misleading. All it really means is any new or any persistent pain after pretty much any spinal surgery. It's also been termed post-laminectomy syndrome. And given this very general broad definition, it may be as high as anything between 20 and 40% after surgery. And of course, we always first want to rule out an obvious structural cause of the pain. Another very good indication where SCS is very effective is chronic regional pain syndrome. And then other indications less commonly practiced are things like peripheral neuropathy, phantom limb pain, post-herpetic neuralgia, post-thoracotomy pain, intercostal neuralgia, and MS pain. And other indications not frequently performed in the US, but actually commonly performed in Europe include ischemic peripheral vascular disease and refractory angina. Those are under investigation here in the US. So in selecting patients, first off, a diagnosis should be established based on objective findings. The area of pain should be amenable to anatomic coverage by a spinal cord stimulator. So if someone, for example, has both bilateral arm and bilateral leg pain, one spinal cord stimulator is not likely to offer them significant improvement. The patient should not be an appropriate candidate for further surgical intervention, particularly for things like an unstable structural problem or an obvious compression of neural elements, or they may be offered that but choose to decline that option. Conservative treatment should reasonably be attempted prior to spinal cord stimulation. And it is very important to obtain neuropsychological testing on all these patients, and that should not reveal any unstable or unoptimized comorbid psychiatric disorders. It may be worth specifically pointing out some characteristics that have been associated specifically with poor outcomes. And this chart takes into account a variety of factors, including the presence of aberrant opioid-related drug use behaviors, suggesting an opioid use disorder, the presence of untreated psychiatric or psychological comorbidities, and other general health factors like a bleeding diathesis or the presence of infection at the site of spinal cord stimulation, which can lead to very poor outcomes. Now, something that's quite interesting is that there are many patients with this nebulous diagnosis of failed back surgery syndrome that land in the territory where there is some clinical equipoise about offering a reduced spine operation versus considering a spinal cord stimulator. And this was actually a really nice study conducted by North et al. That looked at 50 patients at Johns Hopkins University with persistent or recurrent radicular pain after undergoing a lumbosacral spine operation. And that pain was not due to an obvious or unstable structural abnormality. And these patients were being considered for a repeat spine operation, but instead were randomized to either spinal cord stimulation versus a repeat back operation. So 45 patients were available for follow-up, and this table reveals that 47% of patients who underwent spinal cord stimulation experienced a 50% or more reduction in pain, compared to only 12% of those who underwent repeated surgery. So quite a significant difference, with patients undergoing spinal cord stimulation tending to get a significantly more pain relief on the whole. So as many of you know, implanting a spinal cord stimulator is a two-stage process. The first stage may be performed by either a neurosurgeon or a pain management physician, and involves performing a trial, which is usually done by implanting percutaneous electrodes through a Tuohy needle, like you see here, into the epidural space, and guiding those electrodes up to the target regions based on using fluoroscopy. And the goal here, of course, is to cover the spinal segments that are associated with the patient's pain. So typically for neck and upper extremity pain, we target around the C2-3 level. Low back pain is from around the T6 to T10 levels, and lower extremity pain can be from T7 to T12. These are very broad ranges, which is also why a trial can be very effective at honing down the regions or the sweet spot where stimulation can be effective for that particular patient's pain, with a goal of permanently implanting electrodes centered around those regions. There are many possible complications from this procedure, both in the trial phase and in the permanent implantation. You can see here, like lead malposition, migration, breakage, other types of hardware malfunction, infections, CSF leaks, so on and so forth. And neurological deficit is one of these that should not be overlooked. And this is often caused by implanting a stimulator in the face of an existing structural abnormality, for example, a herniated thoracic disc that was missed. And so good rules of thumb are always to obtain preoperative imaging prior to implanting patients, particularly when implanting paddle electrodes. Often these patients are kept awake for the trial surgeries and sometimes for the permanent percutaneous procedures. But if the patient is not kept awake, like for example, typically for paddle insertions, patients are asleep, it's important to use neuromonitoring. Leads should be anchored to the fascia to avoid migration. And of course, just a general rule of thumb, only implant a patient after true efficacy demonstrated on a trial. So as you can see here, there really are a wide variety of stimulator options now available on the market. Here you can see the different types of stimulators, including the percutaneous electrodes, which are these thin cylindrical wires, and the paddle electrodes, which are these flat electrodes, typically implanted by neurosurgeons and require a laminectomy to implant. But really, given all this selection of stimulators and all the different now device manufacturers that are making these different products, it can be really daunting to choose between them. And so I'll spend the rest of the talk discussing some of the advances in the technology. And so it's nice to report that advancements in our field has really exploded over the past decade, both in improvements in hardware, like new designs for electrode arrays, and things like decrease in the battery size and footprint. Also completely new devices and new electrode concepts, like this seen here on the right, which is an IPG-free stimulator, which is implanted without an attached battery, like the rest of our stimulators are typically implanted. And this stimulator is powered by an external battery. But perhaps most interestingly, the field has dramatically changed over the past decade or so because of what I think should be termed the waveform revolution. And this is a difference in how we actually program the stimulator. So, and this over the past decade has really changed how we think about spinal cord stimulation and how patients experience it. It's largely focused on changing the frequency of stimulation, which is measured in hertz or cycles of stimulation per second. So for reference, traditional paresthesia-based stimulation is generally delivered at lower frequencies, like roughly 40 to 100 hertz. And again, as I mentioned earlier, this was thought to be effective based on the gate control theory because of the tingling sensation that stimulation in this frequency range felt by the patient. And it was really only about a decade ago when it was first reported that you could actually get effective analgesia in the absence of these paresthesias or tingling sensations, producing what we call now paresthesia-free or sub-perception stimulation. And since that time, it's been clearly demonstrated that the majority of patients prefer these sub-perception modalities, although a small subset still prefer to feel the paresthesias. And so this field really has exploded and includes the use of higher frequencies, anywhere between 1 kilohertz to 10 kilohertz stimulation, so 10,000 hertz, and other types of waveforms like trains of intermittent pulses that you see here at higher frequencies, which have been called burst stimulation. So for example, 500 hertz bursts of stimulation interspersed over time. And I'll discuss this a little more detail. So this was the Senza trial. It was published in 2015 and was the first of this kind of start of this revolution. Randomized 198 subjects to either ultra high frequency stimulation at 10,000 hertz compared to traditional spinal cord stimulation. And it measured response rates, which they defined as greater than 50% reduction in pain. And so here you can see that this ultra high frequency stimulation provided really rather significant pain relief. You can see here in blue at 12 and at 24 months compared to the traditional modes of spinal cord stimulation here seen in the brown tones. And surprisingly, many of these responders getting more than 50% pain relief actually fell into the category of remitters, which is defined here as an average VAS score of less than 2.5. And so this was true for back pain as well as leg pain seen here. Another novel stimulation paradigm was included in what's been called the sunburst study, which was published 2 years later in 2017. This included 100 patients who were randomized to receive either tonic or burst stimulation. And they received in a blinded fashion one stimulation mode over 12 weeks and then another mode over the next 12 weeks. And this chart describes clinically significant reductions at which they defined here actually as 30% improvement in pain, or what they called responder rates, which was greater than 50% improvement in pain to burst stimulation versus tonic stimulation, and overall showed greater responses to burst stimulation. And furthermore, unsurprisingly, because burst stimulation is generally a sub-perception stimulation, patients did prefer the burst stimulation compared to tonic stimulation. It's worth taking a moment to talk about the idea behind the design of burst pattern stimulation. This was actually designed in an attempt to mimic the bursting patterns of thalamic neurons. And as such, this pattern of stimulation is postulated to target both what are called the medial and lateral pain pathways in the brain. And so the medial pathway is thought to mitigate sort of the emotional affective components of pain, whereas the lateral pathway is thought to control the sensory discriminative components of pain. And so burst stimulation is kind of postulated to affect both. And this has been corroborated, as you can see here, by some functional imaging studies showing activity in regions of the brain involved in this medial pathway, like the cingulate cortex, which is highlighted here. Another new strategy of stimulation proposed is what has been termed differential targeted multiplexed programming, or DTM. This, interestingly, involves the use of variable frequencies, anywhere from 20 to 1200 hertz, with various pulse widths up to 500 microseconds. And all of these different frequencies and pulse widths are programmed into a variety of different bipoles along the course of the electrodes, and each basically run these multiple patterns of stimulation all at the same time. And so this was designed in preclinical studies with the thought that this may maximize glial cell rather than neuronal activation in the spinal cord, and perhaps mitigate pain in that fashion. And the final trial data is currently been submitted, I'm told, and in the review process. But these are preliminary results presented last year that showed that 84% of patients with chronic back pain who received this DTM therapy experienced at least 50% pain relief at 12 months, compared to 51% of patients who underwent conventional SCS. And finally, I'll discuss another waveform programming strategy recently published just last week that is now shifting the focus back to low frequency waveforms. And this particular study was done in 30 chronic pain patients implanted in a multi-center observational case series. And it found that given appropriate adjustments in other parameters like pulse width, they found no significant difference between low frequency waveforms as low as 10 hertz to higher frequency waveforms as high as 1,000 hertz. It also, the study and this philosophy presented here also postulated that these lower frequencies and relatively low amplitude stimulations has a novel electrical field shape that is designed to preferentially modulate the actual dorsal horn itself rather than the dorsal columns, and in fact minimize dorsal column stimulation. Knowing that patients prefer paresthesia-free stimulation, this method is really focused on programming in sub-threshold low frequency stimulation based on initial anatomic paresthesia mapping at lower amplitudes. And this also, makes a good argument that this does provide pain relief and also significantly preserves battery life compared to other modes of stimulation. So in conclusion, spinal cord stimulation has been shown with good evidence to provide significant pain relief in a well-selected subset of patients, with much of the current data focusing on patients who have continued back and leg pain after having undergone at least one spinal operation. Patients should undergo a careful selection process, which includes a thorough neuropsychological evaluation to ensure good outcomes. Spinal cord stimulation technology is evolving rapidly with advances in hardware and really a cornucopia of new programming parameters and furthermore new programming philosophies. And with all these increasing options, it is currently difficult to draw conclusions about which is the best modality of stimulation, but hopefully soon we'll have larger comparison data sets to answer some of these questions.